a definitive diagnosis of SI joint pain. What were your reasons to say the cutoff is 70% and not, for example, 50% or 80%?
Thank you very much for your question. We use pain relief scale to evaluate the injection efficacy. The pain before injection is assumed to be 10. If patient report that remaining pain is less than 3, it is judged 70% pain relief. The remaining pain level of 3 is not strong pain. In generally, in visual analog scale, less than 30 millimeter is considered as mild pain. So we choose the 70%, more than 70% pain relief is criterion of us. If we choose the 50% criterion, it means that it's possible that there is the other pain origin with the same intensity besides sacral joint. We believe that 50% pain reduction is not sufficient to confirm that sacral joint is the main source of pain for the patient. So we choose 70% pain reduction rather than 50%.
Okay.
You understand? I'm sorry, I couldn't explain well.
Okay. And the technique your boss is talking about those 4 zones for the periarticular injection. When I'm doing periarticular injection, I'm just going inside the joint or inside the recess and injecting 5 milliliter of anesthetic, but not targeting different zones. Have you checked if you, for example, do the injection with 5 milliliter of lidocaine or anesthetic, whatever, the contribution or the spreading of the anesthetic in the recess, isn't it the same as if you do 4 different injections with just 1 milliliter of anesthetic?
Thank you very much. So, for therapeutic purpose, we would like to give a large dose of local sticks into the recess, but for diagnostic purpose, the local sticks should be limited in the ligamentous region. If we inject large dose of local stick only in the section 2, the liquid may spread caudally and cranially, and some amount of liquid will spread towards the sacral multifidus muscles and sacral foramen. It is not good for diagnostic technique. So anyway, I have never tried to confirm where the large amount of anesthetic spread to. I will study next. But anyway, so as you say, for therapeutic, so large amount of local anesthetic is good, but for definitive diagnosis, smaller amount of local anesthetic should be injected in each section.
Okay, thank you. Any other questions?
Yeah, I have a question. It's a very interesting talk that Looks like, based on your experience, you use fluoroscopy. Do you have experience with CT-guided injection? Because if you do CT-guided injection, that's true that we radiate the patient more, but is more accurate compared with fluoroscopy. One, and the second question is for cases that they are coming for therapeutic injection. Basically, what do you use? You use dexamethasone or use medicine like Kenalog or Depomedrol plus the numbing medicine?
Thank you very much for your question. The first, I don't often use a CT guided injection because it takes some amount of time and the problem for radio exposure. So we often use the fluoroscopy guide for intrathecal injection. So it's very quickly because I am used to inject under fluoroscopy guidance. For periarticular injections, we often use the ultrasound guided because we have already hyperexposed the radiation. So ultrasound guide is good for my hand. So the next, so I use the lidocaine and occasionally mixing the prednisone for intrathecal injection, particularly for patients with suspected with sacroiliitis. Recently, we studied on that. The patient showed increased pain due to night or rest and the bad weather. So we often administer intraarticular injection such a patient. So we occasionally use prednisone for inflammatory of the joint.
You use dexamethasone or long-acting prednisone?
So its name is dexamethasone ester natrium. Dexamethasone.
Dexamethasone. Thank you.
Thank you.
No other questions?
Well, yeah.
Okay.